and was the dose that gave the maximum improvement in oxygenation. Then another randomized controlled trial was published out of Europe. This study had 268 patients randomized to a dose titration initially to dose find the initial best dose of inhaled nitric oxide and versus placebo. And again, the results of this trial was that it clearly improved oxygenation, but there was no evidence of any clinical outcome benefit. And in this trial, it looked like 10 parts per million was the initial dose that gave the lowest dose that gave the best improvement now in PaO2 FiO2 ratio, and also gave pretty much the maximum decrease in mean pulmonary artery pressure. Now we'll talk about at the end of this segment. That's another reason to give an inhaled vasodilator is to reduce mean pulmonary artery pressure. But in this case, in ARDS, the primary reason is to improve oxygenation. And what you're hoping, or what we were hoping, is that you'd be able to decrease the intensity of mechanical ventilation and therefore decrease ventilator-induced lung injury. One of the things you'll learn as you study clinical trials is that you have one a priori primary endpoint, and that's the only one that you can subject statistical testing to. And then you have a lot of secondary endpoints. Some of those may be positive just because of random effect. Remember that a p of value of 0.05 means that the chance of that happening just by chance is 1 in 20. But a subgroup analysis was reversal of acute lung injury did seem to be favor the nitric oxide, but yet patients alive and off ventilator-free days, as it became known, actually favored the conventional placebo treatment. And you can see here there's no mortality benefit. In fact, the conventional therapy, a little bit better outcome, but not significant in either direction.
Element 2, cafe by the
There's one other clinical trial that was quite large, 203 patients, French study.
Cafe by the entrance.
Used therapeutic optimization to choose a dose of inhaled nitric oxide versus placebo. Showed again physiologic improvements, no outcome benefit. It makes oxygen go up, doesn't produce any clinical outcome benefit. Didier Payen's a longtime friend and colleague of mine. I've asked him, I don't know what happens to some clinical trials that they never get published. I've got one. I don't have time to talk about it, but it was a negative study. It was an innovative compound by a company called Wallace. And I just think I had too many other higher priorities at the time. And then it gets to be a year, then a year and a half, then 2 years, and then you're embarrassed to publish a clinical trial, multi-center clinical trial, when it's been that long. And then this was the big North American trial. I was the lead on this trial, even though I'm the third author, I am the corresponding author. And this is same old story. We use 5 parts per million versus placebo, using a primary endpoint of ventilator-free days, and again, ability to improve oxygenation. one of the things you'll notice in all of these trials, and I'm just showing you for this trial, is that if you compare the inhaled nitric oxide group, that's the top graph, versus placebo, which is the bottom, the oxygen level is higher over the first several days, and then typically by day or 3 or 4, there's no difference between the two groups. And we'll talk about why that may be the case, but also the PEEP was lower, which would imply that the response to the improved oxygenation was decreasing PEEP. And yeah, PEEP is in the calculation of mechanical power, so it looked like you might be on the right track to decrease ventilator lung injury. It just did not happen. This was a study that I think offered some very interesting information. It studied by Gerlach et al. They looked at daily dose titration as part of a randomized clinical trial. So what they did is they randomized patients to a dose of inhaled nitric oxide that they felt was the sweet spot for the initial inhaled nitric oxide versus placebo, 0 parts. And then the group that got inhaled nitric oxide stayed on it for the duration of the trial, and they both had a dose titration daily. So every day, both the 10 part per million and the placebo 0 would have drug turned off and then titrate again to see what the best dose was for producing oxygenation benefit on day 2 and 4. And here you can see from a clinical outcome viewpoint, there was no difference. Now, they did achieve statistical significance despite the very low end. There was only 1 in 20 patients that went on ECMO in the INO group versus 6 in the control. And if you're putting patients on ECMO based on pure oxygenation criteria, you could see if you're able to keep the oxygen up higher for the first couple of days, there might be less people go on ECMO. I can't imagine it would be that difference, 1 in 26 and 20. This was the point I wanted to make. If you look at the control group, every day the dose titration was pretty much identical, as you might think it should be, because they weren't getting any inhaled nitric oxide. But it looked like being on inhaled nitric oxide did alter the dose titration to some degree. You can see that particularly out by the time you got to day 4, the best dose for oxygenation was 1 part per million, which would tend to imply that over time, the sweet spot for dose titration becomes a smaller dose of inhaled nitric oxide. And we know that if you go above and beyond the lowest dose that produces maximum oxygenation benefit, that you tend to lose it. And it's thought that as you put more and more inhaled nitric oxide into the ventilation of the lung, that it penetrates further out from that ventilation and begins to produce vasodilatation away from where you want it to vasodilate, which is just right at where the ventilation is going. And I was also a co-author on the final meta-analysis in 2014. I guess it's good to be on the final meta-analysis because people had pretty much stopped doing clinical trials with inhaled vasodilators, large trials, multi-center trials, placebo-controlled trials. And so we published this in 2014, and there were 9 trials by then, 1,142 patients. And not surprisingly, it showed oxygenation benefit, no clinical outcome benefit. So this was sort of the end of using inhaled nitric oxide as part of a primary outfront therapeutic regimen for ARDS. During that time period, between 98 and 2014, when inhaled nitric oxide was used, people began to look at how expensive inhaled nitric oxide was, which had a primary approved indication in the neonatal for postpartum pulmonary hypertension. And that's where it was being used, and it's incredibly expensive. And that's the same nitric oxide that was being used in adults. So the thought was, why not use yet another different inhaled pulmonary vasodilator, such as epoprostenol or iloprost, which in many places was now used. And there were some comparison studies. I just put a couple of these in This is a study, had a p-value of 0.36, oxygenation improvement a little better with inhaled nitric oxide, but not statistically significant. I can tell you, if I've not seen a meta-analysis, but I don't think you could argue that epoprostenol is better than inhaled nitric oxide. I think the argument is it produces a similar effect and it's a lot cheaper. This is the Cooper epoprostenol or Velletri policy, which has a starting dose of 0.05 microgram per kilogram per minute as continuous nebulized mixing into the ventilation therapy, and then a weaning protocol for weaning it by 0.01 microgram per kilogram per minute. There may be some patients in which higher doses might produce more of an oxygenation benefit, but that 0.05 mic is pretty much a ceiling dose. You know, that's why it's recommended you start out with that dose and then come down. And if you lose the oxygenation benefit, then you go back up. This is from Journal of Critical Care, again, starting at 0.05, decrease by 0.01 micrograms per kilogram per minute. They recommend the decreases occur every 1 to 2 hours. This is from, anybody know what med school UTMB is?
It's the medical branch, University of Texas
What?
Medical Branch in Galveston.
Yeah. You know, having spent 5 years in San Antonio training and 8 years in Houston practicing, UTMB is a very immediate recognition for University of Texas Medical Branch in Galveston, but same thing here. They do mention that every 72 hours tubing should be changed. And just to show you that the 0.01 to 0.05 seems to be pretty much general knowledge for dose range. Now, I know that we've used inhaled vasodilators for COVID, ARDS. The data isn't real good. for it being as good in COVID ARDS as the data in non-COVID ARDS. It may be because of what we think are interesting differences, particularly with the microvascular clotting and some of the other things that are associated with COVID. This study just showed data that it did not produce improved gas exchange. And then here's another study that looked at both epoprostenol and inhaled nitric oxide using in COVID ARDS, combined it, and the median change in PaO2 FiO2 was 0. But anywhere from minus 12.8 to 31.6. This is not a prospective study. This is cohort data, so it's not as good. But you can see responders and non-responders. So you might first look at this and say, well, you know, some patients are going to respond, so you might as well try it. But remember that all of these patients may be getting better or worse independent of given whatever. So that's the problem if you don't have a control. So this is totally uncontrolled data. And you would hope that with cohort data, you would see a change. So what's the indication for inhaled vasodilators in ARDS? It's the right answer on boards, whether it's a single answer or whether it's a case, is salvage therapy only. Salvage therapy meaning that you've done everything else in your armamentarium that we think helps ARDS, and your patient's still hovering around dying from hypoxemia, or has no reserve, or you feel like they're at risk of just going off the edge. That's certainly a reason to consider using it. Now, unfortunately, and y'all, you need to tell me your experience, and I know my team is guilty of this, and since I'm part of my team, I'm equally culpable, I guess, which is you have someone come in with really bad ARDS and you're having a tough time oxygenating, you end up doing a lot of stuff at the same time. So one of the same time things is giving epoprostenol. And I assume you're using pretty much exclusively epoprostenol now, electric. And then you end up with a patient that's on Velletri that you really don't know whether they were a responder or a non-responder. And the only way to find out is to find a time window when you're not going to be doing anything else that might change oxygenation, and do a dose finding titration or titrate it off. I mentioned there are other reasons to give inhaled pulmonary vasodilators, selective pulmonary vasodilators, and that's for pulmonary vasodilatation, which is for acute cor pulmonale. It may prevent arrest or going off the cliff in massive pulmonary embolism, because with massive pulmonary embolism, part of that cor pulmonale is driven by obstruction of the vascular bed and the pulmonary circulation, but part of it is due to release of pulmonary vasoconstrictors. And that part is potentially reversible. Post-open heart surgery, Jason, you're the expert here, but we know that some patients come out of the operating room and have developed acute pulmonary artery hypertension and associated RV dysfunction. And when the RV dysfunction is due to acute rise in pulmonary artery pressure, this may be useful. Jason, I don't know whether you've had an opportunity to use
It's always like a tough place you find yourself in because, you kind of throw them into that class 2 pulmonary hypertension, but then it's acute. So, provided they have like a normal, that their LV function's decent, you don't worry as much, most of them will come out on pulmonary vasodilators. Yeah. And then they, as soon as the PA pressure is normalized, they pull this one and then turn it off. So you never really know if it gets worse, if it gets bad again. So absolutely, yeah.
And then finally, probably the best data is in pulmonary hypertension post-op lung transplant. And I think that's where the only place that it's generally accepted for use with specific criteria. So Brian, since you were the one that wanted to hear about this, did you have anything that wasn't answered? More than
That was wonderfully thorough, and it's great to get the history on it.
probably more than you wanted to know. I know y'all won't say that, but let's see, let me find the other one. So Bryn wanted me to talk a little bit about where do research questions come from. So let's talk about that a little bit. The problem you have when you have an old attending like me is that you find out that you just notice they enjoy talking about old times. They tend to go a little bit overboard with history. And so this was fun for me because basically I just went to my CV and said, how do I fill 30 minutes talking about research questions from my CV? So, and so this was my 4th publication after 3 case reports in 1983. And I thought this was curious when you're talking about how you develop a research question. We were one of that was before I switched from pulmonary to critical care. I was doing pulmonary and there really wasn't critical care. But I got interested in fine needle lung aspirate for diagnosing lung malignancy with nodules. Nobody was doing it. I was in San Antonio and went to Houston and trained with one of the 2-3 people. I spent like 2 weeks there that was doing it. And then I got my first assignment. I was a fellow when I did that. And then I got my first assignment in Biloxi, Mississippi, and taught some other people there how to do it under fluoro. Stick these skinny needles in, and people just thought you were crazy. And we got a lot of pneumothoraces. Nobody ever died. The radiologists were a little bit jealous that we were doing it. And they would be at our conference, and one time there was a real small nodule that I was able to get with the skinny needle, and we showed the tissue diagnosis of the malignancy. And the radiologist said, like, even a blind hog rooted in the dirt occasionally finds an acorn. So I remember that. But what we did, we read this interesting large animal study about they had taken large animals and done fine needle aspirates in the supine and the prone, done it in the dependent and the non-dependent position. So they had aspirates in the dependent and non-dependent, and then they rotated them. And their hypothesis was that if you went to non-dependent lung, that you would puncture less alveoli. And then if you roll them over afterward, it would be denser and you would tend to maybe close up holes. And so they did an animal study and it seemed to support their hypothesis. And we said, you know, we've been doing these fine needle lung aspirates, and as part of our protocol is that when you finish the aspirate, they always lay on their back for 30 minutes in radiology and then get an x-ray for pneumothorax. So we said if we're sticking some in the back and we're sticking some in the front, and then all of them are going supine, you know, we can test this hypothesis to some degree. So we did, even though we only had 15, so 20, 30, 42 patients. But when we looked at the ones that had the posterior stick that were then rolled supine, that satisfied both of their criteria for the non-dependent stick and then the roll versus just one. But we got it published as a letter, and this was in the Blue Journal, American Journal of Respiratory and Critical Care Medicine. And it also reminds me that occasionally you can get data published in a letter, depending on what the data is. And then this is the last one this is the only one I'm going to show you that's really not a good fellow study. And I've shown this to fellows before. Jason, have you told some of them about this study?
I don't think I've told any of them about it, but I remember reading it.
I think
Did you
told
present
us.
this last year?
Yeah.
I feel like some of us know.
I think,
Yeah, so for those of you that this is your first year, so this is 1992. I was over emergency medicine at the county ED in Houston during the major cocaine epidemic. We had people dying of cocaine left and right and bleeding in the head and VTAC, but we're getting a lot of cocaine chest pains. And they'd come in with big time ST segment elevation. And their enzymes would be up and then it would go away. They wouldn't have any focal wall motion abnormality. They'd get cath and the coronaries were normal. So we were trying to figure out what was causing that. And we got IRB approval to get permission from these people to give them IV cocaine before they were discharged. So we took them to the cath lab and we started out with a dose that's in the article, and then we went up to a certain point to reproduce the chest pain. And then we looked at, not only did we look at hemodynamic data, but we also squirted the coronaries. So we reproduced the scenario. In retrospect, do the ethics of that bother me? Yes. But at the time, it just seemed like science was moving forward and we were only doing what they were doing to themselves, but we probably were controlling the dose better and we were doing it in a medically controlled environment. So here's the data. You can see there's no change in the coronary arteries. There was some change in coronary vascular resistance, went down a little bit. Systemic vascular resistance went down, and the reason blood pressure goes up with cocaine, you'll get that big jump in cardiac output. 3.4 to 5.5. So it's more of an inotropic driven rise in blood pressure. So.
Dr. Dellinger?
Yeah.
I think my only question about that study, I think I can't remember from last year, but where did the cocaine come from?
Trauma alert.
That was used to.
Yeah, you can get, they use an ENT. It does have some approved, it's obviously heavily controlled.
Yeah, we have cocaine in our pharmacy. Comes up on rounds sometimes, we talk about it, at least pharmacists tell us we do. They use it for like ENT, for nasal, for nosebleeds and stuff like that.
Most of it comes prepared for like nasal application. It's a little harder to get the stuff that you could use for IV.
Yeah, I see Yaniko on the line. I'm sure she's dying, all the amount of work that goes into getting IRB approval for like an ultrasound study. And you were able to give IV cocaine.
So Krista, I know Krista's on virtual.
I really wish time were different.
What's that?
I really wish that I lived in that time when I can give out
Could you imagine?
people.
What was that?
She wishes she could live in that time. Yeah, could you imagine what she could do nowadays if we could go back in time?
Yeah, it would certainly save you a lot of time, wouldn't it?
Did anyone decline to be in that study?
I think this was probably like a one-page consent form.
Did like every patient, like you just had an IV cocaine, like yeah, of course.
So and I'm sure Jason agrees with me, it's good to know the history of your program here at Cooper. It has a rich history, going back to being one of the first multi-specialty critical care programs in the country. And Dr. Beckus, I think, was the first fellow, and Eric Scott, anesthesiologist, was the first program director. But when Joe Perillo and I were recruited here in 2001 and 2, it was to build up critical care at Cooper. And we were required by the board to create a business plan on how we were going to build critical care. And probably Carolyn's idea, but if you're going to spend this much time and effort in putting together a critical care business plan, why don't you think about publishing it? So we did. Critical care medicine is a distinct product line with substantial financial profitability, the role of business planning. And a lot of people think that the transfer system was only started more recently, but we started the transport system in 2004, called it COTS. But we thought that we could increase transfer from other hospitals because people were like in a sin mode, and we realized that those patients had a good reimbursement status and were good, much better than what walks off the street through the emergency department or comes from the hospital floor. So we built a big program that's continued to grow and gotten boosts here and there. We set up one phone number for referring physicians, immediate contact with unit attendings. Prior to that, it had been residents and fellows turning down transfers. Rapid transfer. We fax back initial findings, follow-up phone call. Went out to hospitals, gave talks, advertised the program, and it was the start of, when I came here, we had 17 ICU beds total, medicine and surgery. So it's changed. And it had a financial plan behind it. You could see the profitability. These numbers were made up. But it was how critical care program got started here. Used to have 2 critical care fellows, I think.
Yeah.
This is another study. Where did this one come from? Translating research to clinical practice. This is also something current fellows probably are not that aware of. When early goal-directed therapy was first published in 2001, the famous River study supported putting CVP catheters in the superior vena cava in everybody and resuscitating them with fluids and inotropes and vasopressors and even blood to try to get the superior vena cava O2 sat to normal of 70%. And that was being done around the country, and we were big early adopters here in Cooper. Juan Carlos, was he?
He was before me, but he's a legend.
Yeah, he developed a cart.
Yeah.
That had everything you needed. So if we had somebody in septic shock on the floors, you fellas just grabbed the cart, had everything they needed to put the catheters in, and the nurses called him Juan Carlos. I'm not going to spend any time, but this, what we showed and got published is that we selected 22 consecutive cases once we put our EGDT protocol in, and compared it with matched historical controls, and showed the feasibility of reproducing a clinical trial environment of being able to successfully achieve the goals of early goal-directed therapy with the formalized protocol, and we got it published in a reputable journal, and it was data that was already there. It was done as part of a performance improvement program, and so it became cohort data. Krista's name is not on this paper, but I'm sure it should have been. But Krista, two things happened that created an opportunity for a great working relationship between critical care and emergency medicine. Krista, you want to comment on that?
Yeah, I mean, I think up until that point, there was always a lot of controversy between the ICU and the emergency department. Each department thought they were better than the other. Obviously, this is quite different now, but this was a project that, we really worked collaboratively on with leadership and nursing. And actually, the ICU and the emergency department actually won a critical care award for collaboration in implementing this program, as well as the hypothermia program way back when. So it was a great project, and it really built relationships and collaboration, not only with research, but clinical care as well.
And your program here was also one of the first programs in the country to take emergency medicine residents and also emergency medicine faculty that were critical care trained even before they could get U.S. boards. The ED docs that got formal critical care training, many of them would take the European boards.
It's interesting you bring up this paper. That was in 2006 or 2007. When I remember the first job that I took in Baltimore, and that was in 2013, they used this paper to build their early goal-directed therapy team there, and they used a precept catheter. Remember that? It's like a triple lumen with a SpO2 monitor. So I interviewed for the job. I was famous. I never worked on the paper, but so I think that's part of the reason why I got it.
And also, these papers had fellows on them. I think Chad Gordon may have been a surgery resident, but this just shows you that this was a survey of surgery program directors, finding out how they satisfied the restriction of hours for surgery residents and still got 24/7 surgery coverage. The Surgery Program Directors Association gave us the mailing address or email address of all the surgery program directors. And we got a pretty good response on the survey. You can see here 24 of 70 university programs. That's pretty good for a survey. 31 of 70 university affiliated. And the results, I just pulled this one figure. That can be done. If you've got a good idea, are you the first person to think of an idea? Like there's a change in how business is done and it may in the hospital and it may impact on training. And you can go to that program directors and society and get permission and send it out and publish the data. This is another example of how you can leverage getting a new technology. Under Dr. I think I actually, Dr. Trzeciak was the lead on doing this orthogonal polarization spectral imaging, putting that probe under the tongue where you can see the sublingual capillaries. And I got him, I had the connections to get it in here, but he did all the lifting for it. And what we did was we looked at patients that had severe sepsis and septic shock, and we got these sublingual capillary images. And then there was like 4 to 6 of us that would meet at the end of the day upstairs, and we would blindly score these. So we could do inter-observer and intra-observer bias, and it was fun. It was a little laborious, but these are the extreme examples. At the bottom, you can see that you just don't see much small vessel capillary flow. All you see is these larger vessels and pretty much attenuation of this branch flow. And then here, you can see you've got a lot of flow in these smaller capillary tributaries. Now, you know the old joke when someone publishes a figure in their paper and says figure 2A and 2B are a typical representation of good flow and bad flow, when it's really like these are the very 2 best we can find of all of our images showing the worst and the best. This is somebody we miss, Constantine Segrelis. Dr. Raboli, when she was head of ID and I was over critical care, before she became dean, had the idea of why don't we bring in a dedicated ID doc that just specializes in ICU for us, is full-time assigned to the ICU, and that was Constantine Segrelis. How much overlap did you have there?
Oh, he was there throughout I think he had, like, when I finished, he had accepted a job someplace else or something like that. But I just remember he would go through this is part of the reason why, I've always been a lazy doctor when it comes to ID, because I always had him go through stacks of data. That was his thing. He would just data mine through a chart and just give you the best synopsis ever. So, whenever I get yelled at by ID docs for consulting, to figure out information, that's how I train.
Most excited I ever saw him was the patient came in with the tick-associated disease. I don't even remember which one it was. And he actually found a tick on the patient. And he brought a microscope up to the front of the ICU and had the dead tick under there and was showing everybody and had a picture of what type of tick it was. But the point here is that this is published in Infection. It's a reasonable journal. I think it's got an impact factor of like 4. It's a case series of 3 patients. And it was during the swine flu epidemic. We had 13 mechanically ventilated swine flu patients here. And of those 13, 2 had coincidental secondary bacterial pneumonia with staph at the time of presentation. So they presented with both staph, bacterial pneumonia, as well as swine flu. So this is what one of them looked like. You see the bacterial pneumonia over here and more of this viral pneumonia looking stuff. And, this is a study that looking at packed red blood cell transfusion on clinical outcomes in patients with septic shock treated with early goal-directed therapy. Again, it's just capitalizing on data that's already there and going back and into the chart and just get data on packed red blood cells. And numbers are small. These are the same 93 patients that kept showing up in a lot of studies. And Krista, these 93 patients, how did y'all get those?
So if I remember correctly, so we had the Project Impact database, so it was easy to pull out, patients who met specific criteria that were mechanically ventilated, had septic shock, and received, we could divide who received blood and who did not. So way back when, during that time period, it was easy to retrieve data for these types of studies. We also actually had the Surviving Sepsis Campaign database at the same time. So we had a number of resources for these types of studies.
Yeah, we used to participate, load all our data in the SCCM. This is also the same 93 patients looking at prior statin use and effect on septic shock, showing that an association between prior statin use and better outcomes. And the last thing I was going to mention, since we're out of time, is we have the ability to tap into big data. Now that John Gowan is gone, Krista, who's the holder of that data?
So our only statistician currently is Crystal Hunter, but Harry's looking for a new statistician. So I imagine the new person is hired will be taking care of that. But if we needed something, we could always tap into Crystal, and she would be able to assist us.
Yeah, this is an idea that Krista and I had. This is based on observations in our own ICU, which is we were beginning, all the hospitals around us were beginning to use scattered bed hospice. And I think that shifted back some in the other direction, but hospice use was markedly increasing in our area. And we felt like we hypothesized, since if you're if you go into hospice, you're discharged from your index hospitalization regardless of what it's for. And now the hospice becomes your hospitalization. So the hospital is not penalized for deaths. So those deaths are not counted. And we hypothesize that mortality should be decreasing nationally in some diseases just based on the effect of the increasing penetration of hospice care. And Krista thought she found, what was the database we used?
It was the National Inpatient Sample. It's a
And-
national database.
Yeah, and we have that here, and we keep buying it when the new one is coming out, so we have the capability. It gives you a lot of ICD-9 and CPT codes. So it's very rich in that for using that as diagnoses and procedures, and it has outcomes. So when we looked at hospital mortality and discharge to hospice care for 6 diagnoses, which were dying with the primary diagnosis of COPD, heart failure, acute MI with cardiogenic shock, septic shock, and lung neoplasm. You can see that at least part of the decrease in mortality is likely due to the increased utilization of hospice care across those. So this is an article that I think is a lot cooler than the reception. I mean, I would have thought that this article would have made a big splash, but it really didn't. How many citations do you even know, Krista?
No, but I used this data in a presentation at SCCM, and somebody put it out on Twitter this week. They had some of the tables that I presented, so it didn't get attention at the time, but it's getting attention now.
For its time.
Yeah, we thought we were going to get in trouble.
Yeah. Well, I think we thought we were going to get in trouble, but yeah. But part of the positive thing about this was that we included folks that were involved with palliative care. So that raised, so everyone became more aware of what was happening. So it wasn't just a critical care study. We involved the palliative care team as well.
Okay, cool. There's my thank you. So thanks, everyone. I'll see you Monday for board review.
So,
Good.
thank you.
Thank you.
Thanks, Dr. D.